Welcome to the Trach and Vent emergency situation in the pediatric home care environment. Key topics will include how to respond to accidental decannulation, trach tube obstruction, and inability to replace the trach tube, and CPR for a child with a trach tube. The first step is being prepared. Knowing why your child has a tracheostomy and the status of their airway. For instance, does your child have a trach because they have some type of obstructive issue, such as tracheomalacia or tracheal stenosis? Or perhaps do they have a trach because they require some sort of long-term chronic ventilation? Knowing why your child is on a ventilator is extremely important. Can the child take breaths on their own? A child that cannot take breaths on their own is at greater risk for safety at any point they come off of the ventilator or the ventilator malfunctions. Knowing your child's baseline suction frequency and secretions is essential to detecting early signs of infection and other acute conditions. Early intervention, early action can decrease possible emergency situations. It is important to know your child. Intervening in emergencies depends on responding in a timely manner and having the right equipment at your fingertips. Your child's emergency to-go bag should be with the child at all times, and its use reserved for emergencies only. It should also be checked on a routine basis. Its contents should include the following: an ambu bag and proper size fitting mask, spare trachs, same size and one size smaller, a suction machine that is charged, suction catheters, emergency phone numbers, water-soluble lubricant, scissors, trach ties, and tape. As the child's caregiver, you cannot prevent every emergency, but you can be prepared for every emergency. In the case of all accidental decannulations, the goal remains the same: replace the trach. First, look at the child. If the child is showing little to no sign of distress and your emergency to-go bag is close by, take the time to replace the trach with the backup trach. If the child remains stable, place them back on their ordered equipment and monitor the child for any signs of trauma that may have been caused, such as signs of respiratory distress or bleeding from the trach. In case of accidental decannulation, where the child is showing severe signs of distress, such as cyanosis or an altercation in their mental status, reinsert the old trach immediately. Once the trach is in place, give breaths using a resuscitation bag, using oxygen if available. If the child does not return to baseline within a few minutes, call for help. Take time to look for probable causes of decannulation, and be sure to document as well as report the incident. Accidental decannulation can occur for many reasons. If the decannulation occurs during a routine trach change and the child is moving, consider swaddling the child. A routine trach change is always a two-person job if possible. The second person is to hold the trach at the adapter and moves with the child. If the child is prone to a lot of secretions, check the tightness of the strings often, as wet trach ties can easily loosen. Know your child. If they have had a recent increase in growth, the position of the trach tube can change and become too short. Also, keep in mind, if your child has a neonatal-sized trach tube, they are at greater risk for the trach tube coming out of the stoma. Make sure to be aware of any equipment, such as a ventilator tubing, that is attached to the trach, as you may need to consider securing the tubing so that it does not pull with position changes. As always, know your child. Good communication is key to most situations in preventing accidental decannulation. A mucus plug is a collection or glob of mucus that is stuck in or at the end of the trach tube and is blocking airflow. Mucus plugs can occur at any time. There is a greater risk in very small tracheostomy tubes or when the mucus is too thick, such as in respiratory infection or lack of adequate humidification. As with any potential emergency, it is important to look at the child first. If the child is showing mild to no sign of distress, such as change in their mental status, or a slight increase, if any, in the respiratory rate, and only slight to no increase in work of breathing effort, such as retractions, you have time to attempt to remove the plug by suctioning. If secretions are abnormally thick, you may want to consider using normal saline to help immobilize the secretions. If, when observing the child, they are showing moderate to severe sign of distress, such as significant change in their mental status or a significant increase in the work of breathing, such as retractions and change of color, cyanosis, perform an emergency trach change. You may need to provide a few breaths using the ambu bag and oxygen to help the patient recover to baseline. Once the plug is removed and the child does return to baseline, you may need to consider preventable causes, such as, is the child receiving adequate humidity and hydration? Does the child have an infection that needs to be treated? It is important that you document and communicate to prevent this occurrence from happening again as much as possible. An inability to reinsert the trach, although rare, can be stressful, even for trained staff. Knowing common reasons why a trach may be difficult to reinsert and interventions may be life-saving. The most common reasons are perhaps the child is upset and crying at the time of insertions. This will tighten the muscles and possibly the skin around the stoma. It may be effective to wait for the child to exhale as muscles are more relaxed. Helping the child to calm down by using distractions can also be helpful. Do not force insertion. Placing a roll under the child's shoulders to promote better accessibility to the airway. If the child has a granuloma or soft tissue at the stoma site, it may be helpful to pull down gently on the stoma site. If interventions are unsuccessful, consider inserting the child's downsized trach. If this is unsuccessful, consider inserting a suction catheter, attachment side cut off, into the stoma and using it as a guide to slide the trach over the catheter and into the stoma site, as you see here. If at any point the child is unstable and stops breathing, start CPR. Again, it is essential that you know your child and their airway. If you know they have a patent upper airway, no history of obstruction, place tape or fingers over the stoma and attempt to give breaths using a bag mask over the child's nose and mouth. If your child does not have a patent upper airway, and the reason that they have a trach is due to some form of upper airway obstruction that must be bypassed, use the ambu bag over the stoma. If air is unable to go in, you may need to pull down slightly on the stoma for air entry. If once you have intervened, trach is intact and in place, and you have a patent airway, and the child remains unresponsive, no signs of life, no breathing, start CPR according to American Heart Association guidelines. Compressions should be at a rate of 100 to 120 per minute. Depth will depend on the child's age and size. Give 30 compressions followed by 2 breaths using the ambu bag on the trach. If oxygen is available, use oxygen when bagging, as this will assist in recovery. The best emergency care is being prepared. Know your child. Your to-go bag, including an ambu bag and charged suction machine, should be with the child at all times. Have a schedule for checking the bag daily. Have a buddy system. Double-checking equipment before leaving the house, along with emergency phone numbers, can be life-saving. Knowing the child's baseline so that signs of distress can be identified and interventions done early, such as a change in the child's respiratory rate, color, or secretions. Advanced planning can improve outcomes. Keep up your skills. Participate in a trach change at least every 6 months. And routinely review the steps for an obstructed airway, decannulation, and an inability to replace the trach.